Hello everyone, welcome back. This is Kanchan Mangale with the continued session for toxic effects of metals. In the last session, we talked about metals, those shiny little things that makes a phone smarter, our jewelry prettier, and unfortunately, our body sometimes crankier. Today, in session 2, we are diving into the toxic side of metals, the side that doesn't glitter. Think of it like a superhero movie, but the villain is a tiny metal ion sneaking into your cells, wearing a cape of innocence. Some metals, like iron, copper, and zinc, are like helpful co workers until they get too enthusiastic and start damaging the office. Others, like lead, mercury, and arsenic, don't even bother pretending to be good guys. They walk in, break the machinery, and then say, "What? I thought this was my place." So grab your magnifying glass. We're about to spot these microscopic troublemakers, see how they mess with our organs, and figure out how the body fights back. Because in this battle, knowledge is our safety gear. So, before we start with our session today, let's have a recap of what we have looked into the session 1. The toxicological pathway of metals or other environmental contaminants from their origin to their adverse health effects on human and ecosystems. What is a metal? Its various properties, physical and chemical, conductivity, malleability, luster, and distinguishing between essential and non-essential metals in biological systems. Metals as toxicants. Certain metals like lead, mercury, arsenic can be toxic, causing cellular damage, enzyme disruption, or neurological effects. Movement of metals in the environment, how the metals travel through air, water, and soil, and how industrial, agricultural, and natural processes contribute to their distribution. The various routes of exposure and absorption of metals, the outlines about how metals enter the human body through routes like inhalation, ingestion, or skin contact, and how they are absorbed into the bloodstream. Distribution of metals in the body. Here we discussed how metals are transported via blood, stored in tissues like liver, bones, and may accumulate in organs, affecting their functions. Metal acting as transporters and metal binding with proteins. This highlights the biological systems like metal thionins and transport proteins that regulate metal uptake, distribution, and detoxification. Lastly, we looked into the excretion of metals, which covered how metals are eliminated from the body via urine, feces, sweat, or bile, and factors that influence the excretion rate. In today's session, we will be looking into the biomarkers of metal exposure, chemical mechanisms of metal toxicology, molecular responses to metal exposure, factors impacting metal toxicity, therapeutic use and toxicity of metals. So, what are biomarkers? Let's start with a simple definition. Biomarkers are measurable changes in biological systems used to detect exposure to metals even before the symptoms appear. Biomarkers of exposure, toxicity, and susceptibility are important in assessing the level of concern with metal intoxication. These biomarkers are important for assessing metal exposure in individuals for clinical or environmental health monitoring. So, what is the importance of these biomarkers? They help us to identify the type and amount of metal exposure, detect early health risks, guide treatment and prevention, monitor effectiveness for safety measures. So we can say that the biomarkers are measurable indicators in biological samples that help identify and quantify exposure to toxic metals. They provide insights to the level, timing, and potential health effects of the exposure. These are valuable in occupational health, environmental monitoring, and clinical diagnosis. Let's look into the biomarkers of exposure, toxicity, and susceptibility. These three categories of biomarkers are essential in understanding and managing metal intoxication. The exposure biomarkers show the amount of metal that has entered the body. Toxicity biomarkers indicate biological effects or damage caused by the metal. Susceptibility biomarkers reveal an individual's vulnerability to metal-related harm due to genetics, health status, or other factors. So, why is it important? It helps to assess the level of concern in exposed population, guide prevention, monitoring, and treatment strategies, support risk assessment in workplaces and environment health studies. The biomarkers of exposure, they are the indicators that a metal has entered the body. What they show is the presence and concentration of metals in biological samples. Some examples are blood lead levels, that is the lead exposure, urinary arsenic levels, that is arsenic exposure, hair mercury content, that is the mercury exposure. So what is the purpose? It confirms contact and absorption of the metal before the symptoms appear. So next is the biomarkers of toxicity. So they are the indicators that the metal is causing harmful effects in the body. What they show? They show the early signs of organ damage or biochemical changes due to the metals. So some examples are elevated aminolevulic acid in urine, that is lead-induced enzyme inhibition, increased beta-2 microglobulin in urine, that is cadmium-induced kidney damage, abnormal liver enzymes in arsenic poisoning. So what is the purpose of toxicity biomarkers? They help detect health impacts and monitor disease progression. Next is the biomarkers of susceptibility. They are the indicators of how vulnerable a person is to a metal toxicity. What they show is a genetic or physiological trait that influence the risk severity. Some of the examples are genetic variants in ALAD enzyme affecting lead toxicity, low glutathione levels, increasing susceptibility to mercury, nutritional deficiencies. Example, iron deficiency, increasing lead absorption. So it identifies the high risk individuals, so preventive measures can be prioritized. So in this diagram, we look into the various kinds of biomarkers. The circle in the middle represents all biomarkers. Each sector represents one category: exposure, effect and susceptibility. The overlap acknowledges that certain biomarkers can serve more than one role. Example, blood lead can be both an exposure biomarker and at higher levels an effect biomarker. Let's start with exposure or intake biomarkers. So this shows that a substance, that is nutrient or non-nutrient or metal, has entered the body through ingestion, inhalation or absorption. So the nutrient intake biomarkers indicate us for essential nutrients like zinc, iron, calcium levels in blood. Non-nutrient intake biomarkers, they are the indicators for toxicants or contaminants like lead in blood, mercury in air. Food or food component intake biomarkers measures linked to specific food sources like omega-3 fatty acids from fish intake. The dietary pattern biomarkers composite measures reflecting the dietary habits, example isotopes of ratios indicating vegetarian diets. Relevance in metals, urinary cadmium, blood lead or hair arsenic are prime examples. The effect biomarkers indicates the biological changes or health effects caused by the exposure, even before symptoms appear. The functional response biomarkers show alterations in the physiological functions, example, reduced hemoglobin production from lead exposure. The risk effect biomarkers indicate a link between the exposure and increased disease risk, that is, the oxidative stress markers from mercury. Relevance in metals increase the aminolevulic acid in urine due to lead, elevated beta-2 microglobulin in urine, cadmium-induced kidney damage. The susceptibility biomarkers, They help to identify how vulnerable a person is to harmful effects from the exposure, often due to genetic, metabolic, or health factors. The nutrient status biomarkers, the nutrient levels that influence toxicity risk, like low calcium, increases lead absorption. Non-nutrient status biomarkers, like other physiological measures affecting the susceptibility. Example is the antioxidant levels. Host factor biomarkers, genetic or epigenetic traits, example ALAD gene variants affecting lead toxicity. Risk biomarkers, they are the indicators that a person is predisposed to harm at lower exposure levels. Relevance in metals, people with iron deficiency are more susceptibility to manganese neurotoxicity. In this table, we will look into where the metals are found in different samples and how they are being entered into the body system. So, in the urine sample, it is due to the recent exposure and soluble metals like arsenic, cadmium, and mercury. They are easy and non-invasive. In the blood, it can be because of recent exposure or ongoing exposure like the lead, mercury, and arsenic. It is good for understanding of acute toxicity. In the hair or nails, it is due to long-term exposure or history of different metals like mercury, arsenic, and manganese. This is due to the months of exposures. The exhaled breath due to the volatile metals or metabolites like aluminum and chromium, it is due to the inhalation exposure. In the saliva, it is found during the population screening. The example is for lead and it is simple and very low cost. In the feces, it is due to ingestion and unabsorbed fractions because of metals like mercury and lead. It is useful in GI absorption studies. In the skin, it is due to direct disposition or visible signs because of the metals like silver and nickel. It is due to dermatitis or agiria. Let's look into the next section, that is the chemical mechanism of metal toxicology. Metals can be toxic because their chemical reactivity and interactions with biological molecules. Their toxicity depends on oxidation state, solubility, and binding properties. A uniform chemical mechanism of toxic action for all metals is implausible because of their great variation in chemical properties and toxic endpoints. Chemically, metals in their ionic form can be very reactive and can interact with biological systems in a large variety of ways. In this regard, a cell presents numerous biological active metal binding sites in proteins and nucleic acids. Such adventitious binding is an important chemical mechanism by which exogenous metals exert toxic effects that result in steric rearrangement that impairs the functions of biomolecules. Now we need to understand why there is no single chemical mechanism for all the metals. The reason behind this is metals have widely different chemical properties like the size, charge, oxidation state, solubility, and cause different toxic effects like neurotoxicity, nephrotoxicity, and carcinogenicity. So the binding and coordination of essential metals in proteins are critical for enzymatic activity, and binding of inappropriate toxic metals in these enzymes are a major mechanism for disrupting normal homeostasis. In some cases, the binding of genotoxic metals like chromium and methyl mercury disrupt the DNA structure, promotes ineffective DNA repair, and is mutagenic. In this slide, we will look into the various chemical mechanisms. Reactivity of metals. In ionic form, many metals are highly reactive. They can interact with various biological molecules in multiple ways. This diversity in interaction patterns explains the variety of toxic endpoints. Next is the metal binding in cells. Cells are rich in biologically active metal binding sites. Examples are proteins. They have reactive group, that is the SH, the NH2 and the COOH, that can bind metals. The nucleic acids, DNA and RNA, can coordinate with certain metals via nitrogen and oxygen atoms in their bases and phosphate groups. The adventitious binding. This refers to non-specific accidental attachment of a metal to a biological molecule that is not in its natural target. So how this causes toxicity? So when the metal ion it binds to a protein or DNA, there is a change in the shape, due to which there is a loss in the function, which ultimately leads to the toxic effects. The binding of metals to non-target biomolecules can distort the 3D structure, that is the steric arrangement. Block active sites of enzymes, prevent normal interaction with other molecules. The result of this is the loss of function in proteins, enzymes or nucleic acids due to the disruption of cellular processes. Some example in metal toxicology are mercury binding to thiol group in enzymes leads to conformational change which creates the enzyme inactivation. Next example is that nickel binding to histones which changes the DNA packaging and altered gene expression. Some of the metals they mimic the requirement of the essential metals. We need to understand why it happens and what are the consequences. The toxic metals often resemble essential metals in size, charge, and chemical behavior, allowing them to trick biological systems into accepting them in place of the real nutrient. The cells cannot always distinguish between chemically similar ions. The transporters and enzymes that normally bind essential metals may accidentally take up the toxic metals. So why it happens? The enzyme inhibition. The toxic metal occupies the active site but cannot perform the required function. So what are the consequences? It leads to the metabolic disruption. The essential metal dependent processes slow down or stop. A structural damage happens. Incorrect metal binding changes protein or nucleic acid shape. So it means that the mimicry lets toxic metals hijack essential metal pathways, which leads to nutritional deficiency and toxicity at the same time. In the table presented, let's see what are the essential metals, what are the toxic metals mimicking them, and what is the end effect. The essential metal, calcium, can be replaced or is mimicked by the lead in its place, which disrupts the neurotransmission and bone metabolism. Zinc can be replaced by cadmium. So cadmium is a toxic metal which is mimicking the essential metal here. So the effect is it inhibits the zinc dependent enzymes. The iron. So the manganese is a toxic metal which is mimicking the impact of iron. So it alters the oxidative metabolism. Magnesium can be replaced by aluminium and it imparts the ATP dependent reactions. In this chemical mechanism, the metals forming into DNA and protein are ducts. Metals in the ionic form can be very reactive and form DNA and protein adducts in biological system. So the basic concept here is in ionic form, the metals are highly reactive and can bind directly to DNA or proteins, forming adducts, that is the metal biomolecule complexes. So you can say that when the metals are in their charged form, that is in the ionic form, they can be very much reactive. So what would be the impact? They alter the structure of DNA or proteins. That is, they can stick to DNA or proteins inside our cells, forming the adducts or the attachments. which causes for the loss of normal function or errors in the replication and repair. That is, this changes the shape and function of DNA or proteins. So they can lead to mutations, enzyme inhibition and cell death. So you can say they can stop the enzymes from working, causing mistakes in the DNA copying and lead to cell damage or disease like cancer. In this table, there are examples of metal biomolecule adducts. So the arsenic, they target the proteins. So the type of adduct here is the sulfhydryl group binding, and the biological effect is the enzyme inhibition or oxidative stress. Cadmium targets DNA or proteins. The DNA adducts and protein thiol binding is a type of adducts. The biological impact is the DNA repair inhibition takes place or the mutagenesis. Chromium targets DNA. The type of adducts which take place is DNA-CR crosslinks, and the impact is mutations or carcinogenesis. Mercury targets proteins. It goes for the thiol binding and impacts the structural protein which is damaged or the enzyme inhibition takes place. Nickel targets DNA and histones. So the DNA protein cross-links is broken and the gene expression changes or cancer risk appears. Here is another mechanism, the toxicity from free ionic transition metals. Transition metals like iron, copper, manganese and molybdenum can easily gain or lose a single electron. This is called one electron reduction or oxidation. When they change oxidation state, they can pass electrons to oxygen molecules in the cell. This leads to the formation of reactive oxygen species such as superoxide, hydrogen peroxide, hydroxyl radicals. So why is this harmful? ROS are highly reactive and can damage DNA, which leads to the mutations, proteins, which leads to the loss of function, and cell membranes, which leads to leakage and cell death. Here is an example of Fenton reaction. The ion reacts with hydrogen peroxide to produce the hydroxyl radical, that is the OH, which is one of the most damaging ROS. While these metals are essential in small amounts for normal cell function, free ionic forms in excess can drive uncontrolled ROS production, leading to oxidative stress and toxicity. The tight coordination of these metals in enzyme catalyzes efficient electron flow and transfer. However, when in excess or unbound, ionic metals catalyze formation of cell membrane, damaging the oxygen-centered lipid radicals and peroxidize, as well as incomplete reduction of molecular oxygen through Haber-Weiss and Fenton reactions with superoxide and H2O2. The resultant lipid or hydroxyl radicals react indiscriminately with macromolecules and are capable of damaging proteins and DNA. One of the example is chromium is an example of a metal that generates metal and oxygen radical species during reduction from its hexavalent to trivalent form. The metals or metalloids such as arsenic that can undergo one electron reduction and the Haber-Weiss reaction are still capable of increasing intracellular ROS, but do so through protein binding and activation of signaling cascades. In the molecular responses to metal exposure, when the cells are exposed to toxic metals, they trigger defensive, adaptive, and sometimes harmful molecular responses to manage the stress. These responses can be protective at low exposure but damaging if exposure is high or prolonged. To say, the exposure to essential metals produce homeostatic signaling for normal tissue maintenance and regeneration, while non-essential metals signal for homeostatic disruption or directly damage macromolecules and tissues. The results include inappropriate activation of growth or metabolic signaling, loss of essential enzymatic activity, direct structural damage, and if severe, cellular apoptosis and or necrosis. Disruption of normal cell signaling through inappropriate growth factor signaling, promotion of maladaptive stress responses, and cell senescence can be detrimental in disease promotion as cell death, especially in chronic diseases such as cancers or cardiovascular disease, where there is little or no evidence of cell death. Let's look into the various factors impacting. First one is the induction of metallothioneins. So what are these? They are small, cysteine-rich proteins that bind metals. So what is their purpose? They sequester excess metals like cadmium, zinc, copper. They reduce the free ionic metal concentration and limit the toxicity. So in the end, they protect the cells by preventing metal interaction with vital enzymes and DNA. Second is activation of antioxidant defense systems. So what is the mechanism here? So the metals that generate ROS like iron, copper and chromium trigger oxidative stress responses. So who are the key players in this? They are the glutathione, GSH. They neutralize the ROS and bind metals. The antioxidant enzymes, superoxide dismutase, that is SOD, catalase, glutathione peroxidase. So they limit the oxidative damage to DNA, proteins and lipid. Next is the heat shock proteins or HSP expressions. So what is their role? The molecular chaperones that help refold damaged proteins. Okay, the metals denature proteins by binding to their active sites or causing oxidative damage. So at the end, they maintain the protein function and prevent aggregation. The fourth is the DNA repair pathway activation. What is the mechanism here? The metal-induced DNA adducts, strand breaks or cross-links activate repair systems. The pathways. The nucleotide excision repair, the NER, the base excision repair, the BER, the double-stranded break repair, homologous recombination and NHEJ. So they maintain the genetic integrity but may be overwhelmed with high exposure. Next is the stress signaling pathways. They are well known as the MPK pathways, which include the ERK, JNK and P38. They are activated by oxidative and metal stress. In turn, they regulate the inflammation and apoptosis and survival. The NFKB pathway, which is triggered by metals to increase expression of inflammation and immune response genes. The outcome of this is they can be protective or lead to chronic inflammation and cell death. Next is the apoptosis, or which we call as a programmed cell death. So this is triggered by severe DNA or protein damage or mitochondrial dysfunction. The pathway for this is the mitochondrial, that is, this is the intrinsic pathway. The death receptor is the extrinsic pathway. The outcome of this is that they eliminate the irreparable damaged cells to protect the organisms. We can say that the cells have multi-layered molecular defenses against metal binding proteins, antioxidants, repair systems, but when exposure overwhelms these mechanisms, it leads to cell death, mutation or cancer. In the earlier slide, we have seen the molecular response of various metal ions. In this slide, you can see a table which represents the molecular response, the triggering effect, the various functions or mechanisms, what is the outcome, the different examples of metals, and we also understand whether they are protective or harmful. Let's start with metallothionein induction. The triggering is excess metal ions. They bind and sequester metal ions via thiol groups. The outcome is they reduce free metal toxicity. Cadmium, zinc and copper are the metals. They are protective. Next is antioxidant defense activation. The triggering impact is the ROS generation. They increase the glutathione, SOD, catalase and GPX. The outcome is they neutralize the ROS and protect the macromolecules. The metals are iron, copper and chromium. They are the protective. Next are the heat shock proteins or HSP expression. The protein damage or denaturation is a triggering effect. They refold the damaged proteins and prevents aggregation. This maintains the protein function, that is mercury and cadmium. They work as a protective response. DNA repair pathway activation. The DNA adducts or strand breaks, the NER, BER and double strand break repair takes place. They preserve the genetic stability. The example of metals are nickel, chromium and arsenic. They act as protective response. The stress signaling pathway activation, which is basically the triggering impact, is the oxidative or metabolic stress. The function or mechanism are MAPK, NF beta activation. The outcome is regulates inflammation survival or apoptosis. Basically it is a lead or arsenic. They are both protective as well as harmful, but they can become harmful if found in chronic conditions. Apoptosis. So it is severe or irreversible damage caused, that is intrinsic or extrinsic cell death pathways, removes damaged cells, cadmium, arsenic and nickel. They are both protective and harmful. Protective in removing damaged cells, but harmful if they are found in excessive. Now everyone must be bored looking into the same old tables, the same old presentations. So let's do something interesting. So in this slide, I have presented how the metals mess with your cell instruction manuals. So in the first slide, you see that the cell, it is following an instruction book. So it says, I am following my instruction book perfectly. Okay. Here comes the metal ion. It says, hi, I'm here to help, or maybe not. So in the second picture, the metal ion sticks to the cell's control switches, that is the epigenetic marks like DNA methylation and histone modifications. In the third picture, the DNA instructions get rearranged. Some genes are turned on when they shouldn't, and some genes are turned off when they are needed. And in the final picture, it shows that if it is in mild condition, the adaptive response is I am adjusting to survive the stress. And if it is a prolonged, the pathogenic response is help, this is causing disease. So now you see, this is such an interesting mechanism which acts together. So after this short beautiful story, we are back to the same old presentation mode. So let's look into some of the factors which are impacting the metal toxicity. So as you all know, the metals are naturally occurring elements that can be essential for life at trace levels, yet toxic when present in excess. The degree of harm they cause is not determined by their presence alone, but by a combination of chemical, biological and environmental factors. These factors influence how a metal enters the body, how it is absorbed, where it is distributed, how it is transformed and how quickly it is eliminated. The toxicity of a given metal can vary widely depending on its chemical form, dose, route of exposure and the individual's age, nutritional status, and genetic makeup. Understanding these influencing factors is essential for predicting health risks, developing safety guidelines, and designing effective treatment strategies for metal exposure. So, some of the factors impacting metal toxicity are as follows: the chemical nature of the metal, dose and exposure, absorption and bioavailability, distribution in the body, metabolism and biotransformation, excretion and retention, host factors, interactions with other chemicals. Here in the picture presented, they are the various factors impacting the metal toxicity. So as you have seen in the previous slide about the various factors affecting. So in this table, a brief description about each of the factors have been explained. Let's look into one by one. The first one is the chemical nature of the metal is valence state, that is oxidation state. Some forms are more toxic than others. Example, chromium 6 plus is far more toxic than chromium 3 plus. The solubility, water soluble compounds are generally more bioavailable and toxic. Organic versus inorganic form. The organic metal compounds like methyl mercury often cross the biological membrane more easily. The complex formation. Metals bound to proteins or ligands may be less toxic or more easily transported. The next is the dose and the exposure. Concentration. Higher doses usually cause greater toxicity. The duration. Acute high dose versus chronic low dose exposures have different effects. The frequency. Repeated exposure can lead to accumulation. And the route of exposure, that is inhalation, ingestion, dermal contact or injection, affect absorption rates. Next is the absorption and bioavailability. The form of metal, the ionic metal absorbs differently than particulate forms. pH of environment, acidic conditions may increase solubility and absorption. Presence of other nutrients like calcium, iron, zinc can compete with toxic metals for absorption. The particle size, nano or micro-sized particles can penetrate cells more easily. Next is the distribution in the body. It can be the affinity for specific tissues. Lead tends to accumulate in bones, mercury in brain and kidneys. Binding to proteins, metallothioneins, hemoglobin or albumin can store or transport metals. Blood-brain barrier permeability. Some metals like methyl mercury can cross this blood-brain barrier easily. Metabolism and biotransformation. The oxidation reduction reactions. They can produce more reactive or less toxic species. The enzymatic transformation. Some metals undergo methylation like arsenic, affecting the toxicity. Interaction with antioxidants. Detoxification may depend on glutathione or other defense systems. Next is the excretion and retention. The rate of clearance. Metal eliminated via urine, bile, sweat, hair, nails or feces. Half-life in the body. Lead can persist for decades in bone, cadmium in kidneys for years. Chelation efficiency. Ability of body or drugs to bind and remove metals. Host factors. It starts with age. Children absorb more lead and are more sensitive to neurotoxicity. Genetic makeup. Variations in metal transporters or detox genes influence susceptibility. Nutritional status. Deficiency in iron, calcium, zinc can increase metal uptake. Health status. Kidney or liver damage can reduce excretion efficiency. Next is the interactions with chemicals. Synergistic effects. Co-exposure to multiple metals may amplify toxicity. Antagonistic effects. Some metals reduce the uptake of others. Interaction with drugs or alcohol. This can alter the metabolism and clearance. The metals have been part of medicines for thousands of years, valued for their healing and antimicrobial properties long before their chemical nature was understood. Ancient Egyptians, Indians, Chinese, and Greeks used gold, silver, copper, mercury, and arsenic in remedies for wounds, infections, and chronic diseases. During the medieval period, Arab physicians refined metal preparations, while Renaissance figures like Paracelsus emphasized that the dose makes the poison. The Industrial Revolution expanded both medical applications and cases of occupational poisoning. By the 20th century, modern pharmacology introduced metals like platinum, lithium, and gold into targeted therapies, alongside growing awareness of metal toxicity and the development of chelation treatments. Before understanding the therapeutic use and toxicity of metals, let's look into a brief history, starting with the ancient civilizations. In Egypt, during 3000 to 1000 BCE, copper was used for sterilizing wounds and water. Gold was incorporated into ointments for skin conditions. In India, through Ayurveda, the Rasa Shastra described purification and medicinal use of metals like gold, silver, copper, iron, mercury, and arsenic. In 2000 BCE, in the traditional Chinese medicine, used mercury sulfide, the cinnabar, for longevity and spiritual purposes. Greece and Rome, Hippocrates and Galen prescribed iron for weak blood, lead for soothing skin ailments, and silver for wound healing. In the medieval period, Arab physicians like Al-Razi and Avicenna refined the preparation of metal-based medicines and noted dose-dependent benefits and harms. Alchemy merged mystical and proto-scientific approaches, leading to experiments with mercury, antimony, and arsenic compounds. Silver, widely used as an antimicrobial for storing water and wine. From Renaissance to the 18th century, Paracelsus (1493 to 1541) advocated controlled use of toxic metals like mercury for syphilis treatment, famously stated, "The dose makes the poison." Arsenic and mercury became common treatments for skin diseases, fevers, and infections, but often led to poisoning. Iron and zinc, recognized as essential nutrients, iron prescribed for anemia-like conditions. In the 19th century, during the Industrial Revolution, the expanded availability of pure metals, medical applications became more systematic. Bismuth and antimony were used for gastrointestinal disorders. The toxicity awareness, first medical reports linking chronic metal exposure due to lead and mercury to occupational diseases arised. Homeopathy and allopathy both incorporated metals but with different dosing philosophies. In the 20th century, that is the modern pharmacology, platinum in 1965, cisplatin discovered as anti-cancer agent, gold therapy 1929 introduced for rheumatoid arthritis, lithium 1949 recognized for mood stabilization in bipolar disorders, aluminium compounds used as antacids and phosphate binders. Toxicology advances improved understanding of dose-response relationships, metabolism, and chelation therapy. Then, in the 21st century, that is the present day, nanomedicine, use of silver, gold, and iron oxide, nanoparticles for targeted drug delivery and diagnostic, chelation and detoxification, refined protocols for treating metal poison, the EDTA, DMSA, DMPS, regulatory controls, stricter safety guidelines for medical use of toxic metals. Dual role were acknowledged. Many metals were recognized as both essential and potentially toxic, with emphasis on safe dose ranges. As we have seen in the previous slide, metals have been used in medicine for centuries, from ancient gold-based remedies to modern platinum-containing cancer drugs. Some metals are essential trace elements like iron, zinc, and copper, vital for biological functions, while others are used as pharmaceutical agent for specific therapeutic effects. However, metals can also cause significant toxicity due to their ability to bind proteins, disrupt enzymes, and generate reactive oxygen species. The fine line between the therapeutic benefit and toxic harm depends on the metal's dose, chemical form, route of administration, and patient-specific factors. So you can say that metals are like old friends. They can be wonderfully helpful when they visit in the right amounts. But if they overstay their welcome, they start rearranging the furnitures in your cells. From ancient gold potions to modern platinum cancer drugs, the secret has always been the same. It's all in the dose. Handle them wisely, respect their power, and you'll keep the sparkle without the sting. In conclusion, metals hold a unique position in medicine as both life-saving agents and potential toxins. Their therapeutic benefits depend on precise dosing, chemical form, and careful monitoring, while their toxic potential demands vigilance in clinical practice. By integrating historical knowledge, toxicological principle, and modern safety standard, healthcare professionals can harness the benefits of metals while minimizing risk, ensuring that they remain valuable tools rather than the harmful hazards. In this table, we will look into the various therapeutic application for different metals or compounds, their mechanism of action, and examples. So, treat iron deficiency for anemia, the component of hemoglobin and enzymes. Examples are ferrous sulfate and ferrous gluconate. Zinc, it is used for wound healing and immune support. Mechanism of action is cofactor for over 300 enzymes. Examples are zinc sulfate, zinc acetate, lozenges. Copper, for the application of rare, the Wilson's disease diagnosis, and enzyme cofactor. It is a component of cuproenzymes, copper histidine used for Menkes disease. Magnesium used for treatment of hypomagnesemia, eclampsia, and arrhythmias. Modulate NMDA receptors and ATP metabolism. It is given through magnesium sulfate injections. Lithium, it is for the bipolar disorder or mood stabilization. Mechanism of action is it alters the neurotransmitter signaling. It is used in the form of lithium carbonate. Platinum compounds, they used basically for the anti-cancer agents, the DNA cross-linking, preventing replication, cisplatin, carboplatin. Gold compounds, anti-inflammatory in rheumatoid arthritis. They modulate the immune responses, used as auranofin, gold sodium thiomelate. Bismuth is used for the treatment of peptic ulcer and diarrhea. The mechanism of action is they coat the ulcers and they provide the antimicrobial action. It is used in the form of bismuth subsalicylate. Silver, it is used as antimicrobial in burns and wounds. It disrupts bacterial cell walls. It is used as silver sulfadiazine. Aluminium, antacid and phosphate binder. Neutralizes stomach acid and binds with the phosphate, usually used in the form of aluminium hydroxide. The arsenic trioxide, it is used for the treatment of certain leukemias, that is the APL. It induces apoptosis in cancer cells and used in the arsenic trioxide therapy. Now, let's look into the mechanisms of metal toxicity. The enzyme inhibition. Metal binds to functional groups in enzymes, often the sulfhydryl or SH groups, altering their shape and blocking catalytic activity. This disrupts essential metabolic pathways. The examples for this is mercury, lead, cadmium, inhibiting thiol-containing enzymes. The oxidative stress. Metals catalyze the production of reactive oxygen species ROS, which damage protein lipids and DNA, leading to cellular injury. Examples for this are iron overload, Fenton reaction, copper overload, Wilson's disease. Membrane damage. The ROS and direct metal-lipid interactions cause peroxidation of cell membranes, altering permeability and causing cell leakage or death. The examples for this are cadmium, mercury, and arsenic. Protein and DNA binding. Metals bind directly to structural proteins or nucleic acids, altering gene expression, causing mutations and impairing protein functions. The arsenic binding to DNA-associated proteins, platinum-based drugs cross-linking DNA. Bioaccumulation. Metals persist in the body due to slow excretion, accumulating in specific organs over time and leading to chronic toxicity. Lead in bone, mercury in brain, and cadmium in kidneys. In this present slide, let's look into some of the examples of metals, their toxic effects, the toxic dose or their source. Iron. The toxic effects is the GI bleeding, liver damage, shock. It occurs due to the overdose of supplements. Due to excess supplementation of zinc, nausea or copper deficiency occurs. The Wilson's disease or contamination is because of copper. They lead to the liver and kidney damage. Lithium leads to overdose in chronic therapy, which can lead to clinical signs like tremors, kidney toxicity, and thyroid issues. Platinum, it is used in the cisplatin chemotherapy, which can lead to kidney damage and hearing loss. Gold, when given for a long-term RA therapy, leads to dermatitis and neuropathy. The discoloration of skin, that is agria, is due to the chronic colloidal silver use. In dialysis patients, when aluminium is used in excess amount, the encephalopathy, bone disease occurs. Arsenic, when used in excess amount, can lead to cancer, skin lesions, neuropathy, and it can basically occur because of contaminated water. Mercury, when found in overdoses in contaminated fishes, occupational exposure can lead to neurological damage. Lead can show the toxic effects of cognitive impairment and anemia, and it occurs due to paint and battery exposure. In the industrial fumes or smoking, the cadmium leads to toxic effects of kidney damage and bone demineralization. Let's see the balancing therapeutic benefit and risks. The therapeutic index, narrow safety margin for many metals. The ratio between the effective dose and the toxic dose, many metals have narrow safety margin, meaning small dosing errors can cause toxicity. Lithium, cisplatin, and gold compounds. In dose control, ensuring optimal therapeutic effect without reaching toxic thresholds. Careful adjustment of dosage to achieve the desired therapeutic effect without exceeding safe limits. Example is controlled iron supplementation for anemia. The chelation therapy used in cases of overdose or poisoning, example is ADTA or dimercaprol. Using chelating agents to bind and remove metals in cases of overdose or poisoning. EDTA is used for lead, dimercaprol for arsenic and mercury, DMSA for lead in children. How it is monitored. Blood level checks for drugs like lithium, platinum and gold compounds. Regular blood level checks to detect accumulation and adjusting dosing before toxic effects occurs. The lithium monitoring in bipolar patients, platinum monitoring during chemotherapy. The patient-specific factors like the age, kidney or liver function and nutritional status. Individual characteristics affect metal handling, including the age, organ function, nutritional status and genetic predisposition. Elderly patients with reduced kidney function require lower doses, iron overload risk in hemochromatosis. Let's have a quick recap about what we have learned in today's sessions. There's a quick memory hook, that is BCMFT. B. Biomarkers of metal exposure. How we detect metals in the body through blood, urine, hair, nails. C. For chemical mechanisms of metal toxicology. The ways metal cause harm by binding, ROS generation, membrane disruption. M. For molecular responses to metal exposure. How the cells fight back. Examples are metallothioneins, antioxidant defenses, and repair systems. F. Factors impacting metal toxicity. Dose, form route, body distribution, excretion, patient health. T. For therapeutic use and toxicity of metals. From life-saving drugs to dangerous poisons, it's all about balance. The final takeaway is, remember PCMFT, the journey from detecting metals to understanding their harm, the body's response, what makes them more or less toxic, and finally, how we use them safely in medicine. Metals can heal or harm. The difference lies in the dose, the form, and the care with which we use them. So, that's a tour through the world of metals. Tiny elements with big personalities. They can be healers, they can be troublemakers, and sometimes they are both at once. The secret lies in knowing the science, respecting the risks, and using them wisely. Thank you for joining me, and may your future with metals always shine in the safest possible way. And that brings us to the end of a journey through the fascinating world of metals. From the subtle clues they leave in our bodies to the chemistry of how they can heal or harm, to the careful balance we must strike in using them safely. Metals have been part of human medicine and history for thousands of years, and our understanding of them has grown from trial and error to precise science. But one truth remains the same. The difference between a remedy and a poison is in how wisely we use it. So as you step away from this session, remember, every metal tells a story, one of potential, power and responsibility, whether in lab, clinic or public health. Roll, you hold the pen to write the safest chapter of that story. Thank you all for your kind attention, your curiosity, and for being part of this important conversation. Until next time, remember, metals can be friends or foes, depending on how we treat them. Stay curious, stay safe, and keep the science shining. For today, thank you.